This podcast is for entertainment purposes only and does not substitute for professional medical advice. Please seek a medical professional or healthcare provider if you're seeking any medical advice, diagnosis, or treatment. Thanks, everyone. I love our projector. It took me a minute to...
It's kind of, no, not the projector. The whole setup is very, what's a PC term? A very impromptu, very...
Who cares? It works. It's like, when have we ever...
It's
we started in a laundry room.
I know.
Every time I come, I remember where we came from. I remember where we came from, girl.
Oh, yeah. And now we have a whole ass teleprompter.
Yeah, exactly. Girl, this is, we keep it real here. Okay.
Anyway, all right.
So
what are we talking about today?
Yes. Oh, wait, we didn't even do the introduction.
I could always forget the introduction.
Yes. Hello, everyone. This is Funny Medicine. I'm Evie.
I'm Julie.
And today we're talking about whole genome sequencing.
This is
predictive health, in newborns.
This is whole, if you guys are tuning in for the first time, she's a pediatrician. So this is her realm.
Yes, This is my realm. This is new stuff that's coming out, but a little bit similar. We already have something similar that exists already. So I'm really happy that we are talking about this because this is huge in predictive medicine, preventative medicine. I think it's a really cool topic. So I'm happy that we're doing it.
Yeah.
All right. So a little clicker. I'm like, all right. So today's episode, we're going to be covering a newborn whole genome sequencing. I'm just going to refer to it as WGS.
I just feel like I'm like this now.
Why?
I don't know. I'm like that. Guys, this is a whole new setup. So, And I always am drifting away, no matter what.
Yeah.
This is a brand new chair.
I'm always having to
Guys, this is a whole brand new chair. If you were around before, stop looking there.
Yeah, no, yeah. God damn it. I forgot that we were recording for a second. Okay, yes.
Anyway, you know what I could do? And I can still see this.
Perfect.
Anyway, if you guys have been following for a hot second, you would have seen that I had a different chair and she was always pulling me. This is a whole ass different chair that she didn't be doing that and she's still pulling me.
Yeah.
I'm still like...
It's okay. Jules and I were literally just talking about our setup. It's crazy. If you saw our last episode, you saw that we struggled.
Check out our TikTok and Instagram and all that. I'll be putting up behind the scenes. It's creative.
Yes, super creative. Physics and everything. Yeah. So, okay. So
back to this.
Today we're going to be covering newborn whole genome sequencing. Yeah. It's a really cool topic. We already have something that's a little bit...
I had no idea what it was.
Yes, we already have something that exists to date, which is similar, but this is kind of like a broader part of that.
More comprehensive.
Yes. This is definitely an emerging medical practice where a baby's complete DNA is decoded at birth to detect hundreds of possible genetic conditions early.
Really cool.
So the goal is to catch these treatable and preventable diseases before symptoms appear. This improves health outcomes and reduces long, stressful diagnostic journeys for a lot of families. I think, one of the biggest obstacles that I face with a lot of people saying, well, I don't want to know. Ignorance is bliss. And I'm kind of on the same boat with that. Me and you have talked about it.
Yeah.
Me and you have talked about it.
But it's different when it's your kid.
It's different when it's your kid. And also, how can I explain it? There's a lot of things that we detect. Like right now we use the newborn metabolic screen, right? And I recommend that full force, right? Because we are trying to catch something before symptoms present. And a lot of these diseases will present with really bad symptoms. You know, some of these babies end up in the ICU, right? For certain genetic conditions. However, I always say, you're born with your genes. You cannot change your genetics. However, if you have information on your genetics, it may potentially answer a lot of questions for your future.
And science has evolved.
Yes.
There are things that could be preventable or could be not per se curable, but they could be treated.
Exactly.
And the earlier you know it, the better.
Exactly.
I mean, there's so many of those. And I'm preaching to the choir. You're a pediatrician. Like, there's things that you could test for early and then be like, well, we could still do something about it. And now with CRISPR, which I'm sure that if you guys are in the news at all.
Check out our episode on CRISPR.
Yes, check that out. But it was even after that there was a baby.
Yes.
What was it? It was like a rare genetic mutation.
It was a metabolic disease.
There you go. And it was corrected, I guess you could say, with CRISPR.
Yeah.
You know, for the first time ever. So medicine is just evolving. Like the earlier you know something, hey, there might be something to help.
Yes, exactly.
You know?
And this is, I mean, this is huge, right? That CRISPR method changing someone's
gosh.
genetics, and it's not perfect. If you read into that case, it's not this like miracle story that this kid is never going to need any treatments ever in the future. There's things that he still needs to go through, but
Very different from
different from
just having it.
and no treatment whatsoever.
Exactly.
And that's just one disease.
And that's the very beginning.
Yeah. Imagine where that could really
go and then 5 years from now even.
Exactly.
If we were able to do that now, 5 years from now, maybe it would be like so much better.
Yeah,
you
definitely.
know? So anyway, all right.
This practice is now moving from small research studies to larger national pilot programs, especially in the UK and the US. So let's kind of dive into that. So what is whole genome sequencing? Whole genome sequencing reads nearly all of a person's DNA. Humans have about 3 billion DNA base pairs organized into 20,000 genes. This whole genome sequencing maps all of these genes plus other regions that help regulate them. Now, we've had whole genome sequencing. We're just talking about specifically now we are doing it for newborns. In the newborn screening, whole genome sequencing is used to look for known genetic variants linked to diseases that appear in infancy or early childhood, and for which effective treatments or preventative measures exist. So we're talking about sickle cell, we're talking about thalassemias, we're talking about spinal muscular atrophy, cystic fibrosis. I mean, I can go on with all of these things, right? A lot of metabolic diseases as well.
Right.
This is something that's so important because a lot of the times when you start presenting with these symptoms, it's kind of like now you're catching up with the pathology of it.
Yeah, it's not too late, but it could have been better or easier earlier on.
Yeah, or just knowing.
Yeah,
right?
exactly.
Signs, symptoms, what to look out for.
Right.
Don't wait on a symptom. You know?
Absolutely. Okay.
So compared to standard newborn screening, which tests for a few blood markers for about 30 to 60 conditions, which by the way is not just in one hospital. This is national.
Right.
Okay. So every state has their newborn metabolic screen.
And it's the heel prick, right?
Yeah, it's a heel prick. Exactly. It's just literally just a prick of blood and it's marked onto a piece of paper and it's sent to the Department of Health and then they go ahead and run it and make sure that nothing comes back alarming.
Okay.
Or abnormal. Or they even tell you if you're a carrier of something.
Right.
So, which I think is even better.
So if you've had a kid, that's what it is. Like that little heel prick, that's what she's talking about.
Exactly. Which we'll talk a little bit of like people not knowing what it is. Exactly. So compared to standard newborn screens, which only test for like about 30 to 60 conditions, whole genome sequencing can check for hundreds of rare diseases in one single test. Standard screens mostly detect metabolic and endocrine disorders that are measurable by byproducts in the blood. Many other genetic diseases don't leave biochemical clues at birth and remain hidden until symptoms appear. And that can also be different because just because you have a genetic disease doesn't mean that phenotypically your outward expression, your symptoms of how you're actually going to manifest that disease is completely different from person to person. So it's kind of like, one person may have a strong phenotypic expression compared to another person with the same genetic disease, right? But with different presenting symptoms. So it's not that simple, just like kind of waiting. Not everyone is the same, even though you have the same genetic predisposition. Okay.
Right. Got it.
Whole genome sequencing is going to really close that gap.
Okay. Makes sense. So, history. So where did this all come about? Who thought of this? All those things, right? So modern newborn screening began in the early 1960s, believe it or not.
Yeah.
Dr. Robert Guthrie developed a simple blood test for ketonuria.
Phenylketonuria, PKU. It's mostly known by PKU.
PKU.
Yeah.
A metabolic disorder that can cause severe brain damage if untreated. Before Guthrie's tests, children with PKU usually developed irreversible disability because it was not detectable until symptoms actually appeared. So the Guthrie test used a heel prick blood spot and a simple culture dish. It was easy, cheap, and transformative. By catching PKU at birth, doctors could put affected infants in a special diet and prevent brain damage. And that's massive, you know? So PKU screening began to be the standard in the US by the late 1960s. Over the decades, the heel prick became a universal part of newborn care. The United States now screens for about 30 to 60 conditions, with each state setting its own list. These panels include metabolic disorders, endocrine conditions, blood disorders like sickle cell that she had mentioned, and some other congenital heart conditions. In the UK, for instance, the standard quote-unquote blood spot tests, which is what they call it over there, screens for only 9 rare diseases, making it a lot more limited than in other countries like for us, for instance. So every condition added to a screening panel must have an accurate test, an effective treatment, and an early treatment must make an actual difference, right? This is to ensure that screening does more good than it does harm.
Yep. And also, you know, even though each state is different, I've compared.
Yeah.
Because sometimes I get patients that are born in different states and I need to check their newborn metabolic screens, but it's fairly similar. Like, it's not like one state will test for like 15 things and another will test for 60.
Right. I mean, that makes sense.
Yeah. All right. So how does WGS, I can't say WGS, it doesn't sound right.
It feels like you're going to say wigs.
Yeah, exactly.
Right, yeah.
How does whole genome sequencing work in a practice? So for a newborn, the process usually starts in the same way as the heel prick test. It's a small blood sample that's taken. DNA is extracted from that blood and then fed into a next generation sequencing machine. These machines read millions of DNA fragments all at once. Specialized software pieces those fragments back together into the baby's complete genome.
It's so freaking cool. Just think
Very
about
complicated.
that.
Yes, exactly. So
Like-
small fragments goes to a machine, and then that machine brings all of those fragments back together to kind of map out a whole entire genome sequencing.
Incredible.
Yeah. So now the
Informaticians.
this is a big word. Bioinformaticians,
AKA people that like
study bioinformatics
and analyze all of this fragmentation,
and
putting together
geneticists,
and all that.
Which, my goodness, if you're a
Oh,
geneticist,
props to you.
props to
'Cause
you.
Genetics.
That is a very hard field.
Oh my God, I hated genetics with a passion.
It's a very hard
With
field.
a passion. It was so like, I don't know, abstract's not the word because it's not really abstract, but it felt like it was. And it was like so like, what?
My first,
I don't even
funny
know.
story.
Oh my God.
My first,
And that's undergrad. That's nothing in comparison to
my
you.
first rotation as a resident
Yeah.
was genetics
Oh, God,
in
no.
a genetics, my genetics clinic. And
Lord.
can I tell you that for being my first ever
Yeah.
rotation, that was hard. That was really, really hard. It's just a very niche
Yeah.
part of medicine.
That's a good way of terming it.
And it's pediatric genetics. You know, a lot of these things get diagnosed as a child, not as an adult.
Right.
So, God, every single time I was at the hospital and I needed to consult genetics, I was just like, thank God. I was like, bless your soul for existing. Because it's a really hard field. It's a very hard field.
It's
and they
so
are,
technical too. It's like,
if you see those notes from a
Oh.
geneticist, I was just like, wow, I didn't even notice that. And then all of a sudden, like, it just changes everything. Like,
like, oh my God.
yeah, exactly. I was just like, I had no idea that. Yeah, okay. Anyways,
Yeah, no,
So-
you got to be a special breed of person.
yeah, no, and they are very well sought after.
I'm sure.
You know, if a place has genetics, that's massive. So, anyways, so these bioinformaticians,
Very smart people.
geneticists, yes, then compare the baby's DNA to a large reference database that will catalog known pathogenic variants, which are gene changes confirmed to cause disease. Okay, so they basically have this whole entire portal, right, with all of these genetic diseases. So these people, these professionals, these clinicians are taking all this information that you're getting and really analyzing it, and kind of, it's not just all very, you know, like, oh, you got this is what you're gonna have,
Right.
this is your risk, you know, like it's not that easy, it's not that straightforward. So they need to take all this information,
Analyze it.
and analyze it and really interpret it
Exactly.
to each individual patient. The analysis focuses on actionable pediatric conditions only. Typically, adult onset risks, conditions with no known treatment or findings that have no medical use in childhood are not really reported. The aim is pretty clear. It's to want to identifying a disease early, if it's going to appear in childhood or not, allow the doctors to start monitoring or treating before the damage occurs, and then avoid unnecessary information that causes worry but has no medical use.
And that makes sense. I mean, if it's based off of the PKU by Guthrie, it's like identify that the kid has PKU and then like stop it before it causes brain damage. So it's all going.
You have
so
to be on a
based-
specific diet, and that was the whole
Exactly.
entire PKU. You don't have an enzyme that metabolizes a certain
Right.
thing, so you need to have a certain diet so that you're not ingesting that certain amino acid. But anyways, they did a whole entire panel when we were in medical students, and we got to meet
Yeah.
kids and adults with PKU
No shit.
and their story. The adults basically saying that they didn't have this like testing before, so it took
No
them
way.
forever to diagnose him, and it was all
And how
no,
old
it
were
was
they?
he was already like an older kid by the time that
Okay.
they diagnosed him, but it all was just like, I remember the man saying all I needed was just a specific diet.
Dang.
Like, he's like, everything else is manageable if I just
That easy.
avoid eating the amino acid.
And it like goes back to the mind gut thing.
Yeah.
Like, everything always ties up to that. Like, there's so many of our episodes, if you guys have been following us, there's so many of our episodes that we like go back to the mind gut
Yeah.
connection to it and all that. But
This is like definitely like genetically connected.
oh no, yeah, it's genetically connected, but it's also like just introduce a diet and watch how
And
it
watch
fixes.
how it fixes it. Yeah. Kind of along the same principles. Yeah.
It's just like a
No, and then for babies, now
Right.
they have formulas specific for babies.
wow, that's awesome.
Yeah. So it definitely changed a lot.
Yeah.
So results are shared with the family through genetic counseling, which I think is, you need that. It's not just like, get this and, I don't understand why people do all these like genetic like workups and like all these things if you're actually not talking to someone that specializes in the field.
Yeah.
But I'm preaching,
Yeah, I mean, there's a lot of people out there just trying to make money, so.
Yeah, exactly. So for routine screening, this may take a few weeks, but for critically ill newborns in an intensive care unit, rapid whole genome sequencing can really deliver results in under a week and sometimes even in days. And that newborn metabolic screen will test for some of these diseases that present the first 3 to 5 days, like the first week of life. And we're talking about problematic pathology that causes a newborn, a 1-week-old baby, to have crazy low blood pressures and, really, really difficult to manage pathology and symptoms.
Yeah.
And if you did one test, you could have possibly been able to address it immediately.
Right.
So even like SCID, like severe combined immunodeficiency, which is like what we call bubble boy
Oh, okay.
or whatever, it detects that too. So it's
Wow.
like, it's all these things that you're really able to detect just with the newborn metabolic screens. I can
Yeah.
only imagine the whole genome sequencing.
Exactly.
No, so routine screening, we're going to talk a little bit about the differences between whole genome and routine screening. So for routine screening, it's usually just a blood spot test and you detect for these chemical markers. Now it's going to detect between 30 to 60 treatable diseases, and it covers common metabolic and endocrine conditions and with well-established treatment pathways. Now, the whole genome sequencing is going to analyze the actual DNA, detect hundreds of rare diseases, including many not detectable by biochemical tests, and then it identifies conditions with clear treatment or preventative options. So it also provides a single test for multiple disease categories. So metabolic, cardiac, immune, neurological. There's a lot more in that whole genome sequencing. For example, a child with a hidden genetic heart rhythm disorder may not show any signs until they're playing a sport and they faint.
I'm sure you've seen that.
Yes, there was a case from the kid in Belen.
Yes.
He died.
Yes.
He passed away.
Yeah. Oh, God.
Yeah.
That's so sad.
He had something else. I mean,
Yeah.
he had a genetic disease. Okay.
But there we go.
Yeah, he had a genetic disease, and unfortunately, he had an arrhythmia, and he passed away.
Dang.
Very, very sad. But which is actually So now, I don't know if you noticed, but they passed a bill. Now we need to do routine EKGs for all sports, even if you don't have any cardiac risk.
Good.
Yeah.
Good. I mean, what's an EKG?
Exactly.
You could prevent something like that happening.
Yeah, it's literally just an EKG. So this is an example. This child has a genetic disease, and you won't know until they either faint or they have a sudden cardiac arrest, okay, which is a heart attack, okay, in adolescence. Very rare, but can happen.
Yeah.
Okay, so at whole genome sequencing, at birth, you can identify that gene variant, allowing doctors to monitor heart health, get your EKGs every year. If you're going to do sports, we need to maybe do a couple tests to see if you can do these sports. Right. How does that, detect?
Yeah.
Exactly. And, once you're identified, then they test your parents to see where that came from. It all gives you a lot of information. It basically allows doctors to monitor heart health and prescribe medications for implants early. Okay. And that's just for the specific example.
Yeah. So, I mean, we're talking about all the wonderful things that it could do. Now, there's actual conditions that it could detect, right? So the common categories that it does detect is, like she had mentioned before, the metabolic disorders. So beyond PKU, dozens of enzyme deficiencies that can cause brain damage, liver failure, or severe illnesses. If left untreated, they can be detected by this. So like she had just literally mentioned right now. So primary immunodeficiencies, conditions like SCID. So severe combined immunodeficiency, like the bubble boy, right?
Yeah. Mm-hmm.
So fatal if untreated, but curable with early bone marrow transplant.
Yes.
So it's like actual curable disease,
Mm-hmm.
Anyway, so cardiac arrhythmia syndromes. She had just mentioned it too with this example of a kid in Belen, unfortunately. For example, long QT syndrome, which can cause sudden cardiac death in children or young athletes. Early detection means monitoring medication or devices to prevent life-threatening events. And then you have your neurological conditions. So some genetic epilepsies respond to specific diets or medications that can reduce seizures if started early. And then you also have your sensory conditions. Certain forms of genetic hearing loss, such as Pendred syndrome, can be caught before hearing loss actually affects speech development. And then you have your pharmacogenetic risks. So some babies carry genetic variants that make common antibiotics cause permanent deafness. The whole genome sequencing can identify these risks upfront and prevent these babies from having to encounter that,
Mm-hmm.
So I don't know. All of this is really, really cool.
Yeah, it gives you so much information.
Yeah.
Still, I think you should go over it with a geneticist.
Yeah.
But and it's so funny to me how in this day and age, we do it really like, it's not just like when the baby is born. The moms are getting tested for, I got tested for cystic fibrosis.
I got tested for everything.
I got tested for everything, so it's kind of, for me, I find it, not odd, but surprising that it's not just standard to have a genetics consult.
Yeah, you're right. Maybe it's because of the lack of how many geneticists are out there.
Yeah, can you imagine?
Yeah, exactly.
All right, so let's jump into a couple of real world examples. The Guardian study is sequencing up to 100,000 babies in New York. Among the first 4,000 babies sequenced, about 3% had treatable genetic conditions not found by routine screening. For example, multiple babies were diagnosed with G6PD deficiency, which can cause really severe anemia if certain foods or medications are given, stressful situations, illnesses. This condition is not part of the New York's standard panel. One baby was actually found to have SCID, which you do test for in the newborn metabolic screen. But this is a life-threatening immune disorder. The whole genome sequencing caught it early following a bone marrow transplant that saved the baby's life. In Belgium,
they have the BabyDetect.
The BabyDetect, yeah. Belgium's BabyDetect pilot uses a targeted panel of 405 genes. About 90% of patients opted in. Over 70 babies were found to have hidden genetic conditions, including metabolic disorder, not caught by standard tests. And then one baby's test flagged a false positive, but follow-up tests clarified the child was healthy, basically demonstrating the need for expert interpretation.
So like you were saying, the geneticist.
Yeah, exactly. Yeah. And that's really common. Again, this is a screening, right? Mm-hmm. We use it as a screening. If something comes back positive, we're obviously going to follow up and confirm that. In North Carolina, they call it the early check. So parents can volunteer for free genome screening. So far, over 2,000 babies tested, dozens found with early onset conditions. One baby's risk for Pendred syndrome meant early hearing checks following timely interventions. There's also major global initiatives. In the UK, in 2025, the UK government and NHS announced a £650 million investment to sequence every baby born in England within 10 years.
That's a lot.
There is a pilot to sequence 100,000 newborns, which is underway through the Genomics England Newborn Genomes Program. It's a long name.
It is.
Now, the pilot screens for about 200 to 250 rare conditions with proven treatments. Genomic data with parental consent may be stored securely for research and future clinical use. Now, in the US, no national rollout yet, but major pilots. The Guardian study, the largest US trial for universal newborn genome screening. The Begin NGS, led by Rady Children's, testing healthy babies for 400 plus genetic conditions. The Early Check state-level pilot offering free whole genome sequencing for families in North Carolina. And then private companies like GeneDx offers optional commercial newborn whole genome sequencing. Now, GeneDx, which is diagnosis, gene diagnosis, has sequenced over 15,000 newborns already. Other countries like Belgium, Australia, Saudi Arabia, and some EU nations have small pilot studies testing how whole genome sequencing can complement traditional screening. I feel like preventive medicine is so important, and
It is.
this is such a big step for
And
preventive
I feel
medicine.
like insurance companies should cover this full on, because
No, girl.
they're saving money by that, you know? It's just, I know. It just doesn't make any sense. It really doesn't
It
make any
doesn't,
sense.
right? Like, it's something preventative, and
So you're saving money in the long term.
exactly, but no.
Yeah.
I mean, they cover the newborn metabolic screen. So,
But they didn't cover, like, for instance, when I did the color test when I was pregnant, they
they didn't cover
any-
that, yeah.
No.
Yeah.
None of those
didn't
genetic
cover
tests do
that.
they cover.
Yeah.
It's really weird.
Yeah. Now, some ethical considerations. Consent. Babies cannot consent, so parents decide. I don't understand how that's ethical. Like,
I don't know how this is a conversation, really.
it's like, I don't even know how this is a conversation.
Yeah.
If your baby,
Yeah.
okay, is
Yeah.
involved in an accident,
Exactly.
Okay.
So what, you're going to be like, I can't.
and they're in a coma,
Right.
they're 15, but they're in a coma, they can't consent. So you're going to make a decision for them.
I don't get it.
Right?
I don't get it.
It's crazy to me.
Yeah, it
it's
is.
crazy to me.
This whole, like, consent thing about babies lately, it's become a lot more tracking. And I'm just like, dude, it's a baby.
Yeah.
Your job is to take care of the baby.
Yeah, this isn't an ear
is your job.
piercing.
Yeah,
Yeah.
exactly.
You know?
Like, your literal job as a parent is to take care of that baby.
Yes.
So you have to make decisions like this
Yeah,
on their
exactly.
behalf.
Yeah.
You know, like,
Yeah.
I don't know how this is a conversation.
So it's an ethical, consideration that people have to have that
Sure.
parents need to decide. Sure. I think you already know where me and Joel stand.
Yeah.
So ethical principles stress that genetic screenings for newborns should focus on childhood onset actionable conditions. Adult onset diseases that are risks, are generally excluded to protect the child's right to decide later. I think that this is where Alzheimer's,
Right.
comes in, Parkinson's.
That are going to affect the child later in life.
But again, we're talking like, what about like these cardiac conditions
That's it,
that may not
yeah.
present until adolescence,
Exactly.
So it's,
But that's what I'm saying. Like, in the later stage in life, like in your 40s, 50s, 60s, onward. Okay, maybe have that conversation. But like earlier stuff,
yeah,
like that's your job as a parent.
exactly.
A 60-year-old is still not legal. So
Yeah.
you still are making that decision for that child
Exactly.
to like become an athlete. There's plenty of athletes that are 15, 16, and they unfortunately suffer through these things. So hello.
I know when you did the DNA in me, was it the DNA in me? that
The
tested-
23andMe.
The 23andMe that tested
Yeah.
you for like medical conditions.
Yeah.
You said that you had to wear more sunscreen because you were
Right.
more at risk for
Melanoma and all that. And my
Okay.
skin's more fair, et cetera,
Okay,
all
so
that shit.
I never did that, so I
Yeah.
can't like have an example. But let's just say your mom had that ability
Yeah.
to do it before. I am positive your mom from a young age would have been like, Jules, you need to wear sunscreen.
Yeah.
You are a person that you
Absolutely.
need to wear sunscreen.
Absolutely.
It's almost the same as having a family history.
Yes,
It's like, hey,
yes.
your family has a lot of diabetes. You need to take care of
Exactly.
yourself and all these things. It's the same thing.
Same thing.
So all right.
Yeah, it truly doesn't make any sense to me. This,
Yeah.
I mean, you're literally scapegoating not being a parent.
Yeah.
To me, that's
Yeah.
what it is.
Exactly.
Because that's your job to
job,
protect
yeah.
your kid. But whatever. Anyway.
Yeah. So, uncertain findings. Some variants have uncertain significance. Not all mutations guarantee a disease. Clear guidelines and follow-up are, confirmatory testing will reduce overdiagnosis. But again, if something screens positive, you need to go to a geneticist.
Right.
Now, the problem that I see here is that sometimes getting an appointment
Oh yeah,
with a
it takes
geneticist
a year.
is forever.
Yeah.
So unless that there's something, right away needs to be addressed, that I'm like calling myself the physician's office, like, hey, squeeze this patient in.
Right.
I mean, but that's really hard. That's really, really hard.
And that's the thing. It's a lack of geneticists out there.
Yeah, lack of doctors, because this
I was gonna say.
I've had a neurologist that I called myself for a baby that I was concerned about, a very severe diagnosis that ultimately will lead in death. And, I was concerned, and I said, can you please see this patient earlier? They're telling me that you're not available for another 3 to 4 months.
Yeah.
And she was like, if the baby presents with seizures or something that you feel like is a seizure, tell them to go to the hospital, and I'll see them at the hospital. Because they are consulted at the hospital, sat, so they go and see them, and it's they can't fit them.
Right, in the clinic they're stacked.
I can hear it in her voice that she wanted to, but she cannot. And that's what a lot of people that are not in this field don't understand. It's not that we don't want to see you. It's just we have other people high above us, okay, that expect us to see 30, 40 patients every single day, max 10 minutes, because if we take 15 or 20 minutes, for a full patient, they're like, why are you taking so long with that patient? They're literally like down our throats. So it's not that we don't want to spend more than 5 minutes with you. It's not that, trust me, if I could sit down and have a full-blown conversation, I feel like medicine nowadays would be completely different.
And unfortunately, it's becoming worse because they predict, at least that's something that I saw as scrolling in our social media that's all full of like doctors and all that stuff and whatever. By 2035, there's going to be a massive shortage of primary care docs.
Yeah, and the whole entire thing with the big, beautiful bill. Horrible, that capped to the loans.
Yep.
Okay. There will be a shortage.
100%. There's
and
no
people
doubt.
are like, medical schools are going to lower their tuition.
No, they're not.
No, they're not, honey.
No, they're not.
No, they are not.
They make too
You
much
live
money.
in a bubble world if you think that is going to happen.
Oh my God, no. So primary care docs, which is what you go for with the flu and anything that is the common
your doctor,
ailment out there, your common doctor, your doctor that you go for anything.
Yeah.
There's going to be a deficiency on it.
Yep.
That is insane to me. That's insanity to me when I saw that. And then you actually look up the statistics and it makes sense. Like all the residents, no, let's not even talk about residents. There is new residents. There's a different breed going in right now.
Yeah.
And they're very unaware of things as they are.
I can't tell you the amount of times that I had to go get lunch and sit in the workroom and chart.
Or just not have lunch.
Or not have lunch because you do not
even be able to pee. Like,
oh my God.
Mario's an attending and he has no time to pee sometimes.
Yeah.
Sometimes he keeps trying to go to the bathroom and then he's like, crap, I can't because I got to call.
I think a lot of people are going to come back at us and being like, well, you are accepting like that kind of environment.
You had no choice.
No.
You had no choice.
No. This is a high stress job that you
demanding.
You are. It's like physically, emotionally, mentally demanding. Okay, the whole entire time. And I'm sorry, like if I'm like breaking it to you, then that's what it is. And whoever paints different colors is lying to you.
Yeah.
Okay.
100%.
Don't get me wrong. There are some physicians that have a nice life.
Oh yeah.
But the majority,
especially if like you're in a hospital
like
setting or anything like that,
it is not like that. Okay, even in clinics, I can't tell you the amount of times that I finished seeing my morning patients, because I have a 12 to 1 block.
Yeah.
Okay, for that hour lunch. yeah, no, I've never taken an hour lunch. And again, I'm not here like, as an attending, if you're my resident, I'm going to push for you to get your lunch break.
Yeah.
Can I promise you that it's going to be an hour? No, man. I don't think you're going to get an hour lunch.
You'll probably get the amount of time for you to eat it.
Exactly. I'm like, you can take 20 to 30 minutes, probably, but you have work to do.
Yeah.
And you know what? If they told me, hey, I'm going to take an hour lunch, but don't worry, I'm going to get the work done by the end of the day. Perfect.
Yeah.
Manage how you want to manage your time. I'm not here to micromanage what time you eat, what time you don't.
You don't have the time for that.
I don't. So whatever you want to do, you can do. Okay.
Yeah.
It's just not realistic.
It's not.
And I think that's what this generation, and I don't want to say this generation, but I have seen a trend.
There is a trend
in the new workforce.
It's weird. Yeah.
And there is a lot. And don't get me wrong, I do think that wellness for residents needs to be improved. And I do feel like a lot of residents are overworked. I am 100% with you on that. Yeah. I was burned out as a resident.
Yeah.
I was burned out as a resident and no one cared. Because every time that I would complain, you know what my attendings would do? They would tell me how much they suffered when they were residents.
Exactly.
So it's like a generational thing. Okay. So no one cares.
Yeah.
No one cares. Do I feel like, looking back on it, do I feel like I can take on a lot? I can take on a lot. And it's like they almost like fire hydrant, you know?
Exactly.
Like that.
Or like push you into the pool.
Push me into the pool and they're like,
figure it
out. That's how residency is. But sometimes now, as an attending, I look at it and I only had 3 years of pediatric training. We only had 3 years to train. So I am positive that that is the mentality that they need to have. They're like, sink or swim, my love.
Yeah.
Sink or swim, because you got 3 years to be out on your own.
Exactly.
And I will say, some of the residents that I've had, I'm like, if I would have been like this in my residency, they would have kicked me out. They would have kicked me out. I cried. I've been broken.
Of course.
I've cried.
Dude, of course.
You know, there are some angry tears. You know when you're so angry that you cry?
Yeah.
There's been some angry tears that happened to me. But what doesn't kill you makes you stronger. And I never want to have that. Like, I never want to make a resident cry. I don't believe in that. I believe in a very positive workforce environment.
It's not the way to
it's a
teach.
learning environment.
Yeah.
However, if you suck, I'm going to tell you that.
Yeah.
You know? And you gotta in a constructive criticism way. I'm not going to tell you suck, okay? But I'm going to tell you, hey, if you're not able to finish your work, if you're not able to keep up with the flow, if you are not prepared during rounds, that doesn't mean that if you start at 8, that you come at 8. If you know that you're not going to be prepared, I expect you to show up at 6 a.m. to pre-round on all your patients and be ready 100%. That's what I did. When I was in the hospital, when I was at wards, our ward started at 7. Our shift started at 7. You know what time all of us would get there? 5:30. 5:30 to round on our 14 patients because we needed to be ready for rounds. Notes started and halfway completed so that when we were done with rounds, we were signing them and getting ready for admissions.
It's just, you know, the thing is that there isn't room for error in your field.
Yeah.
And that's the problem. A lot of people that are coming into this job, they're like, oh, it's just a job. No, you're dealing with people's lives. It's a whole different pressure that you guys have to deal with. Okay. So the job's going to be different. The training's going to be different. The expectations are going to be different.
And if you're not that person that is going to take that extra mile, go that extra mile,
then maybe this is not the job.
Then maybe this is not the job for you, because I cannot tell you in medicine how many times I've had to go the extra mile.
It's part of the job.
You know, sometimes you need to hold the patient's hand, the family's hands, and walk them through every. I have called myself during office hours. I have called myself to schedule appointments for patients.
That's it.
Because I just know that if I don't do it, if I don't literally give you your appointment is on this date at this time, and I've told parents, I'm like, do not miss this because I took my time to make this appointment for you.
Right.
And they're like, yes, ma'am. You know? You have to do it. And if you're not willing to do that, I don't think that this is the career for you.
That's it. That's the thing. And a lot of people, I really feel like they go into it thinking that it's just like a job. And it's not something more than just a job. It's not, you're not pencil pushing. You're not behind of a computer the whole time. You're treating people life and death. You know, it's different.
Yeah.
It's going to take more.
It's going to take more. And I'm sorry, your first year interns, my love, your first year interns, the intern year fucking sucks, man. It sucks. The learning curve is very vertical. There is no flat planes to ride. It is fully vertical upward learning curve. Okay. So yeah, intern year sucks. There's a reason why it is known, it is very well known that intern year sucks.
Yeah.
But it gets better.
Right.
It does. I will say my second and third year, I did not feel like how I was. And let me tell you, it doesn't get easier. No. That's another thing. I mean, I know I just said that it doesn't get easier. It's like a different stress.
Right.
Right? It's like you're kind of growing with it. And some things do get easier, like that learning curve is not so steep, but other things get harder.
Yeah, exactly.
And then I thought that that's it. After residency, I was like, oh man, like I'm finally attending things. Nope. It's still hard. And I see more patients.
Exactly.
And I see more patients.
And you train now too.
Yeah. And I train, and I train everything. I train medical students, PA students, NP students. So I train a lot.
Yeah.
Okay. And I have to also, like, the way I train a resident is not how I train an NP.
Right, of course.
Very different. And I don't mean any disrespect to the resident or to the NP.
Yeah.
It's just, I was a resident.
Yeah.
I am a physician, right? My training, I was not, I learned from my peers that included NPs, okay? That included nutritionists, physical therapists, and stuff like that. But my main training was from mine attending. So I trained that way.
Right.
Training a completely different field.
Yeah.
Sometimes, sometimes I've had them say this is a lot. And I'm just like, buckle up.
Yeah. Exactly. You're like,
buckle up.
Yeah.
Take advantage that I'm your preceptor.
Right. Right.
Like, don't get me wrong. Yeah, maybe it would be smoother or something if you had like the same profession training you. But if you're expected to take care of patients,
that's what I'm saying.
On your
own,
there's
a different expectation.
Buckle up,
with
man.
these careers.
Yeah.
So that's why it's gotta be tough. You gotta give a lot. There's a lot of sacrifice. There's a lot in many different realms of your life. And you got to know that that's what you're going to do. And it's not just a job. It's more than that.
Yeah.
But anyway.
We just went on a massive tangent.
But we are going to do eventually, we are going to do like a little series on
medical school,
residencies,
trainings, different types of fields of things.
On that. I know that people want to hear that, especially like people that are thinking of going to med school or are in med school or are residents.
That want to know the difference. What's an NP? What's a PA? What is the difference?
Know.
Why do they need to practice by themselves? Who sends
the
meds?
way that people are completely unaware of what it takes to become a doctor.
Yeah.
Entirely unaware.
Yeah.
And no clue.
I mean, I don't blame them. If that's not your thing, that's not your thing.
Of course. But it's so different from like every other career.
Yeah.
So we'll definitely jump into that. We will make a series on that at some point. But anyway, here we are.
All right. Back to what we were saying.
I don't know how we jumped from that to this.
Back to whole genome sequencing. Wow.
How? Whoa. That was a leap. Yeah.
Bringing it back.
Okay. All right.
Bringing it back.
Yeah.
All right. So back to whole genome sequencing. Let's talk about uncertain findings. Oh, we already talked about that. That, you should go seek counseling from a geneticist just because it's going to reduce overdiagnosis. Yes, exactly.
There we go.
But anyways, so privacy. Okay. Genomic data is lifelong health information. So programs must secure data storage, control the access, and protect against misuse. So in the US, the GINA law prevents health insurance or employers from using genetic data for discrimination, but does not cover life insurance. Okay. This is BS.
It is.
Because
it is.
I've been questioned by insurance agents when they ask me what my past medical history is.
That's what I'm saying.
And I'm like, why I'm still paying the same policy?
Exactly.
Yeah. So
Yeah. But insurances be insurance.
Exactly. Yeah. But Gina law, hilarious. Now the family impact. So a baby's results can imply parental or sibling genetic risk. This can help other family members, but also raises like privacy questions about shared genetics. But I'm not just like, this is your family.
Exactly. But I mean, it all depends also on like, I guess the relationship between the family, maybe like, I don't know. But
yeah, but if I have a disease, right?
I know.
And I potentially have a sibling.
But you're a rational human being.
Yeah, I guess. I was just like, I was going down the lines of that. Yeah.
Yeah. There's people that are just, there's things missing up there, you know?
Yeah, seriously. All right.
So cost and coverage for all of this, because it does sound wonderful, right? So why not freaking have it? Whole genome sequencing now costs about $1,000 per genome and continues to drop, luckily. Sequencing all babies in a country like the US would cost billions annually, hence why it's not like the national norm. Standard newborn screening is usually public health funded in the US and the UK. We're talking about like that heel prick one with the standard ones per state, you know, those ones that we had mentioned. Now, whole genome sequencing pilots are funded by research grants, charities, or partnerships with sequencing companies. Insurance companies currently cover whole genome sequencing for diagnosis when a child is sick, but are hesitant to pay for routine screening in healthy babies. More large studies are needed to prove that early detection saves enough money by avoiding expensive treatments, like I've been saying. Like, hello, insurance companies, like this is potentially going to save you money. Yep. Some families choose to pay for private whole genome sequencing services for peace of mind. But this raises concerns about equity if a whole genome sequencing becomes widely available only for those who could afford it. I mean, but that's unfortunately for a lot of things in healthcare.
Yeah.
You know, it's like who could afford what, and like treatment and seeing somebody sooner than later. And at least here in the US, it's unfortunate, but it's the truth. 10 impacts on healthcare for this, right? So clinical use today, rapid whole genome sequencing is already used in the NICUs for very sick newborns with unexplained conditions. So studies show that 30 to 50% of these babies get a genetic diagnosis within days instead of years, often changing treatment immediately. Long-term vision for all of this, stored genome sequence genome data can be reanalyzed as science progresses. New treatments can become available, allowing doctors to check the genome for new actionable genes without retesting. So it's like I'm saying, like you don't, right now we had like that CRISPR thing, but in 5 years from now, we don't know how much better it can get, you know? Potential future. If whole genome sequencing becomes routine, a child's medical care could be customized across their lifetime, from monitoring drug reactions to screening for just general certain conditions in adulthood if the individual chooses to, you know. So yeah.
All right, let's talk a little bit about the key challenges. So one, accuracy. There are false positives and it's uncertain, right, the findings, but if you do have a false positive, we do further investigate to confirm that, okay? But you can get a false positive for anything.
That's what I was gonna say, like blood tests.
For anything. You also have the psychological impact. Families need clear counseling to avoid unnecessary stress. I 100% agree with this. There was a law that was actually passed when I was a resident. There was a law that gave everyone like live access as everything came in. If I got results, you were available to see those results.
Yeah.
I agree with having access to your results after a certain time. Okay, give me a chance to see your results, to contact you, right? I cannot tell you the amount of times that I get a result and the patient's already, hey, I saw this red flag. And I'm like, it doesn't mean anything. And also, I haven't reviewed your results.
Yeah.
You know? So give me some time. You know?
I could see that, yeah.
And also, like, there's some things that aren't released, right? So, like, an HIV diagnosis, that's not released, even though it is. Like, I've had patients be like, hey, like, this flagged or whatever. And then I like, have to, you know, it's like, stop what I'm doing, like, all these things. It's kind of just like...
You could have gone to it.
I'm going to get to it, right? And it's just a different a different approach to things. Right?
Exactly. You could have been more dedicated to it, you know?
Yeah, or not just that, but like more prepared and,
Right.
you know, like look at other things. And then all of a sudden you have like a consult that you didn't expect you were going to have, and it's over the phone. There's some things that are better done in person. You know, the approach is everything.
Yep.
Right. So it's like when you have people see everything live, it's kind of just like, yes, you can have access to it. Like, that's not what I'm trying to say. Like, you have fully rights. It's your blood, right?
Yeah.
But at the end of the day, it's like, don't freak out about something because I haven't gotten it to it.
Right.
And if it's critical, trust me, it's gonna come to me.
Yeah.
I'm literally gonna get a ping at 2 o'clock in the morning, right? That there's a critical result. It's just things like that.
Yeah.
Now, capacity. More early diagnosis means more specialist care. And health systems have to ensure that there's enough pediatric geneticists, like we have already discussed, and counselors that are available. And that's a big problem.
Yeah.
And it's going to be a bigger problem now that we're fully going to expect physician shortages after the big, beautiful bullshit. Now, cost benefit. Large studies must show that whole genome sequencing saves money and improves quality of life enough to justify the national funding. And this is where I feel like the problem lies, right? There are some people that are going to have life-changing results, right? But there are some that you're going to have to like kind of wait to see. And this is where I feel like insurance agencies are going to be like,
that's where we're going to grab onto that.
Exactly.
Yeah.
So now let's talk about future outlook. So experts widely agree that whole genome sequencing for newborns will become more common as costs fall and evidence grows. So the UK aims for universal rollout by 2035. That's crazy. That's just 10 years from now. That's amazing. If pilots prove effective, I'm pretty sure they are, just by like the minimal amount of like information that we've had so far. The US may follow a state-by-state approach. Get me started. Oh yeah. Every single line I'm like just like shriveling inside. Genomic newborn screening could transform public health, adding hundreds of treatable conditions to current panels, helping families avoid diagnostic odysseys. Right? Odysseys? Yep. Odysseys. And allowing more proactive care. I mean, it's all about being proactive, right? Of course. We cannot change your genetics, but if we have that information, that can answer a lot of questions.
So, controversies and challenges, you know, because obviously when we're talking about genetics and stuff like that, it's going to be riddled with it, unfortunately. So why is this trending even? Why are we even talking about this today, right? So while newborn whole genome sequencing is generating headlines for its promise to detect hidden diseases early, it brings concerns that experts, parents, and policymakers are debating about it now. The first one that we had talked about, the consent and ethics situation. Babies can't consent, obviously, and that's why you are a parent. But anyway, parents agree on their behalf, but whole genome data lasts for life. Critics argue that it's a big decision to lock in without a child's choice. Most pilots only report childhood onset treatable conditions to protect future autonomy, avoiding adult onset or untreatable risks. Even so, some DNA results come back uncertain, which can leave families anxious about those maybe risks that may never become real problems, actually. Then the next one I do agree with, which is data privacy and security. Because every day you wake up and you see the news that somebody else got hacked. A baby's genome is their ultimate personal, record. Large-scale sequencing means storing millions of DNA files, raising questions about who controls it, how it's kept secure, and whether government, insurers, or even law enforcement could misuse this information, right? In the US, some states already keep newborn blood spots for years. Cases have shown that these samples have been used in criminal investigations. For instance, to get the Golden State Killer, they got through Ancestry.com. That's how they found him. Anyway, this is sparking some backlash and calls for stricter privacy laws. If genomic data leaks, it cannot be changed. So data protection is a major worry. Now, the next one is overdiagnosis and the psychological burden that could bring, right? So whole genome sequencing can find risk factors for diseases that might never develop. This means some families could face years of extra testing or stress about conditions that may just never appear. The term overdiagnosis, which is finding something that might never actually matter to the person, is why it's being talked about. Families need clear counseling so they can not carry this lifelong worry over an ambiguous DNA result if it does happen. Studies show that many parents handle this well, but it depends on careful follow-up and communication. Next up is access and cost. Right now, whole genome sequencing is for healthy babies, and it's funded by research grants or paid privately, which can widen health gaps, which are already pretty freaking wide here in the US. If only wealthier families can afford DNA tests for early answers, health equity will suffer because of that. Public health experts say that if whole genome sequencing goes mainstream, it should be free and covered like standard newborn screening. Every baby benefits. Cost is a major factor, though, because it costs about $1,000 per baby, and that adds up at a national scale, at least here in the US. Hopefully that could, with time, lower, and then maybe it could become something more national. And then you also have your scientific limits, because this test is not, it's powerful, but it's just not perfect. Some diseases are still best found by biochemical tests, so heel prick screenings won't disappear. Some DNA variants are hard to interpret. A baby may have gene linked to a certain disease, but never develop symptoms, which is like when people talk about being a carrier and whatnot, you know? So interpreting uncertain results is still a work in progress. And lastly, commercialization and public trust. So large pilots, especially in the UK, partner with biotech companies and pharma to build DNA databases that also fuel new drug research. Critics also ask whether parents fully understand their baby's DNA might be used for commercial research. Balancing public benefit with private profit is part of this ongoing debate. It's something very new. It's going to be riddled with, tug of war type of situations. So it is what it is, And lastly, just to put a bow on this, it's trending now because in the UK, mostly the NHS plans to sequence every baby genome by the next decade.
Yeah. Mm-hmm.
And then here in the US, as she had mentioned, the Guardian study that was also brought up. So is
the one in North Carolina,
North Carolina and all that. So it's just, there's a lot going on that right now. And I think it's interesting. I think it's useful, but the costs need to go down in order for it to become more like the heel prick one.
Yeah, or just be covered. But as long as they don't take away the newborn metabolic screen.
Exactly.
Maybe we can add on to that. Maybe it's
exactly.
something that we can kind of find a happy medium for.
Right.
But I definitely feel that we can test more than just what we're doing right now.
Exactly. Yeah, the science is there, so why not?
So why not take advantage of it?
Right. Anyway, thank you guys for tuning in. Leave a comment below if you have anything, anything to say about this. If you're in the UK, let us know if you're already seeing this happening, because apparently this is a big topic over there in the UK.
Or maybe you're a patient that you had something discovered by this whole genome sequencing.
Exactly. And we're on pretty much every form of social media. That's Funny Medicine Podcast. We also have our email if you want to contact us directly away from social media, which is funnymedicine305@gmail.com. And yeah, thanks for tuning in, and we'll see you on the next one.
Bye.
Bye.